and it also plays off what I just said about the fact that we've already invested so much money codifying so many things in healthcare. And you get down to, well, why don't we use it very well? Well, we've gone on about financial disincentive to use it and perceived notions that they can get more out of keeping it than sharing it. But there's just been a culture of standardization that stays on paper. In many cases, people then pay for those standards. That's actually what pays for the standards organizations. In HIPAA, I think there's 3 organizations named out by law you have to use, and that's why they get fees. The CPT codes used for billing, AMA gets about 80 million a year from that, as far as I know, something like that. That's a bandied figure. They'll never give you the exact figure, but that's always the one tried around. And so what you have is a mixture of private and semi-private and some public coding schemes. People use this hodgepodge all over the place, and you've data brokers who then gather that together for you, and various hospitals for their drug-drug interaction data, they go to First Data Bank owned by Reuters, and you have the CPT coming from AMA, and if you want to go to Medicare. So we paid for all of this, basically. This is public funds, and NIH paid for this, but for one reason or another, people got in between, including organizations like AMA that would, I presume, claim that they're doing a good service by making sure they charge you every time you express yourself. The idea of the semantic web was, if you make it relevant for what I just said, when Berners-Lee came up with the web of documents, which we use every day, very simple stuff, one of the big things was the URL, and it was open linking, because when he came and started looking at the web stuff, there were CD-ROMs at the time, remember Encarta and all that stuff? Mm-hmm. He didn't make up hyperlinks. He didn't make up the fact that documents linked together. He didn't make up the fact there was hypertext that embedded those links. You could get a very pretty looking thing from various parties, encyclopedias and these CD-ROMs. What he made up was the fact that everything could link freely to everything else, and so that you had open linking. And in fact, when he showed his hypertext mock-up to his boss, the guy was totally underwhelmed, because he had just bought one of these encyclopedia things in a CD-ROM for his daughter, which was much prettier, much better looking, and lovely images and lines. His was an ugly looking thing with blue, you know, the hypertext was underlined in blue. This was before the horrible blinking stuff that came afterwards. But it was not something that would impress. But the revolution was not the aesthetic. It was not the underlying technique. It was not the fact that was markup. It was the fact that the links were open. And that meant that, that documents that I create can link to your document, to Tom's. When Tom said, I have something on my site, it links out to something else. Now you have an open world. To an extent, Wikipedia is open, and then it kind of links out as well. Bit by bit, more and more parties try to close in so you'd stay in their universe. But eventually, even they have to link out. And that's what was different from that and, say, Facebook, which today is trying to go the other way. It's trying to make a web-based Encarta, if you like. One of the problems we have in healthcare is the fact that you have these islands of coding, and you have these islands of data, whether it's patient data as one sort in the hospital, or you have know-how of one sort or another, you know, medical codes, even the underpinnings of interpreting the genes, the disorders that you, from simple things to more complex ones, what procedures used to treat a disorder, all these are coded, that's all in know-how. The patient data, the observations, their social life hopefully as well, and other things, although right now it tends to be just this vital, this medication, this prescription. And of course the last group are providers. And here's the wonderful thing we face in medicine, which you don't face when you talk about lunch, which I alluded to there. This is all codified. There are identifiers. You can't practice medicine without, you have an MPI. Every hospital, every clinic has one. So every single thing is uniquely identified, and you can turn that into a URL. Right? You can give that a URL. Now you have been uniquely identified by something that's web resolvable. All of this know-how is codified. Yes, we have redundancy. The National Cancer Institute is its own. The NIH comes out with stuff. The FDA has codes for drugs. The NIH is their RX norm, then you have First Data Bank with their things, so they overlap. There's a lot of redundancy and synonyms in there. But basically there's a whole bunch of codes. Every one of them can be turned into a URL. And obviously the patient data itself, observations, these are just, in web of data terms, it's a triple. It's subject, predicate, object, simple sentences. Everything in the sentence is a URL. The subject, the patient themselves get one. The predicate, what you're saying about them, get one. But the most important thing is what you're saying, like has hypertension. Hypertension is the know-how URL you've just declared about them. Who was the doctor? They saw Dr. Jones. That's a URL. In time. Time's obviously the other thing behind this. And when you start looking at it this way in web terms, specifically not web of document, but web of data terms, you can effectively, right now, without coming up with any new standard, take off the shelf web of data standards and the huge investment we've made codifying medicine and publish everything out there. Every hospital, every small clinic, basically publish it. Everybody working for them that's a medical professional has naturally a unique URL. And all the know-how that they practice, otherwise they couldn't bill it, which means it doesn't exist if they can't bill it, has a unique URL. So you can make statements about it in terms of the patient. We don't have to invest a dime to actually do that. And the protocol is HTTP. The underlying web infrastructure is there to transport it. We can apply the access control techniques we use in banking and other things for that data. There's nothing new needed here. And actually that's one of the problems with it. There's no new job, there's no standard body job in this. There's no, you're not going to give a big grant to one of the large academic health institutions to do this because there's no new definition needed. There's no new document. CMS, HHS, maybe there's a guidance they put out, but that's about it. 30 pages, you're fine. A few examples. And you could basically have patient data interchange and know-how interchange, observation interchange. When you get into the gene and that huge amount of data that's going to happen, it basically just links into all of the clinical observations we now have. The downside, and Tom and me have exchanged a lot of information on this, I've put in stuff into HHS about this, and you basically get these blank things. No, we have standards for these things, and this is very important. And oh yeah, that's fine, that's kind of a novelty. How does that fit in with the HL7 knowledge interchange standard? How does that fit in with the CCD meaningful use codified version 3 standard? And you're going, well, actually, that's all a bunch of rubbish, right? That's never going to go anywhere. That's like the OSI stuff, remember? Because it's from the same notion of top-down in Cathedral. This you could just do now. A web administrator could start putting up this stuff.
It's also true that within know-how right now, at least academic research, there is a lot of internal stuff that is browsed by.
PubMed, all the articles, they classify it using a thing called mesh. They are all unique identifiers that can be URLs. So effectively, if you want to data mine better all the mesh, actually the people do this. With the genetics at the talk at Osira by some of the genome people up at, wasn't it Stanford? They were using mesh IDs and mining the literature and trying to correlate it back to the genes that they had. So
excuse me, Conor, let me ask Nico, how much time do we have left on the?
26 minutes.
26.
Yeah, I'm
so
just done. I've basically rambled through as
I
fast
want
as
to
I
have
could.
Christoph talk a little bit.
Yeah.
Go ahead.
I basically said what I quickly wanted to say, which was we don't need new stuff. It's already there. We just take the infrastructure we have. But the biggest barrier is just that people want some, particularly in healthcare, they think they're special. So they need a custom infrastructure. Not true. They think that they need new things if they've got a problem when they've already spent all this money already giving themselves identity. And identity is the biggest data exchange problem. Identity. They've already spent billions on identity. They don't have an issue with it. Well, that's a hard sell because they're not used to it mentally. They need the new blah blah committee of interchange, overseeing ONC. It's basically like Homeland Security. Remember, after the misfortune of 9/11, we discovered we had 14 intelligence agencies. Well, the solution to that was not to say we should have maybe 3 or 4. It was, well, let's put an agency over the intelligence agencies, and that's generally how healthcare thinks as well. So when we've been talking about this, it's a very hard sell, not because conceptually it's simple, right? It's the fact that it is that, and there wouldn't be a lot. It wouldn't put oil back into the machine, and they wouldn't keep going like that.
What Tim did with the URL though is he created an information space. So he created a space. Wikipedia is a space, and it's a space metaphor of anything can link to anything else, and it's open, and there really isn't a top to it. There isn't a top left-hand corner to the web, and and there's no center. You just start and you go, and there's no center or top to Wikipedia. There is a center or top to every HL7 thing. HL7 only works in the instance of an action when something has to happen. to trigger the transaction. If something doesn't happen, HL7 doesn't even know about it. Things that don't happen in healthcare are often far more important than things that do happen, but we just can't talk about those things. So the idea of creating a space that doesn't have a top left-hand corner, and isn't based on this integration crunch model of, oh my gosh, we have 47 different hierarchical outlines we have to fit together in this Humpty Dumpty syndrome thing, to say, okay, we're just going to have this very fine granularity, large-scale network, very regular repeating structures, the privacy, the security and all that stuff could be layered on these individual objects. So it makes a whole lot of sense. I think it's a lot simpler and cheaper than what things are going, which means somebody's going to lose money.